क्या हुआ? वहाँ पे आता है? अच्छा, so I can point out with the cursor, no?
Yeah, you can. It's visible on the...
Yeah, it comes there also.
So I'll just check if the mic is...
Only the screen will go, no? The screen will go.
The screen will go on Meet, sir, and on YouTube there will be an inset of your this feed.
YouTube पे भी जाते हैं?
Yes, sir.
अच्छा, because you इस पे 100 तो होते ही नहीं है Google Meet पे.
So उस पे 100 नहीं होते, but there are some.
I thought YouTube is active only after 100 or so.
So normally residents नहीं होते. Someone else, people other than other alumni, if they want to join, they join through the YouTube link.
Right. बताओ कब शुरू करना है? How do I get to know that? How do I get to know the attendees or not? इस पे तो नहीं आएगा.
इस पे आएगा सर, मतलब
If needed, I can.
If needed, we can switch to the Chrome tab. जिसमें Meet is on.
Okay.
So around 30 people are already. I'll just.
So I can log in on mine also, I suppose.
You can.
And I can see the list. So link आज अगर हमने भेजा ही नहीं होगा मेरे पास.
So if you're there on the faculty resident group.
No, I'm not on WhatsApp this week.
Okay.
अगर हमने भेजा है आज link. अब link बताओ.
I'll send it.
Just send it me quickly.
Ritesh?
Yes, sir.
Ritesh, please send message in all resident group to join immediately.
Yes, sir. I've already sent it.
Okay, resend it again. And good afternoon, sir. Sir, you can start. It's already 4. Or if you want to wait, you can wait.
Praful, just a minute. Yeah.
So can you tell me?
VNKYP RAO at Yahoo.
Sent.
Chalo, I'll start. I don't think I guess if I got the connectivity. Yeah, Praful, should I start?
Sir, you can start, sir, please.
Okay. Yeah, good evening, all of you. when I first saw the teaching schedule, I was surprised by the topic that was given, white dot syndrome, largely because these are very rare lesions and they're poorly understood, and it's unlikely to kind of affect any of your clinical practice or patient diagnosis later on. So I was trying to collect some information, update myself. We have seen almost all of these lesions, maybe except Azure, in our center. So I have a collection of my own, but at the same time I thought, let me update myself. And then when I was looking up the literature and on using one of the academic search engines, I got 600 references to white dot syndrome. While I was going through these references, I reached somewhere around 160, 180 or so, and then I suddenly started seeing that there's something called white spot syndrome. And in the interim, you also see that most of these references are only case reports and case reviews. There are very few, case reports and case series, almost 90+% case of references. There are only few reviews and some individual write-ups that are there on this topic. So the first question I would like to start my lecture with is, I would request all the residents, particularly the senior residents, to write yes or no to this. White spot syndrome is caused by a virus. I'll come back to the concluding part of my lecture to answer this particular question. So when you talk about white dot syndrome, what all of us conjure up is that the retina has a lot of lesions that are white in color. They're probably smaller in size, and that's what comes to our mind. So I'll show you a series of pictures, again a collection from our center, and all of you please write whether this is a white dot syndrome or not a white dot syndrome, and I'll come back again to these kind of images in the concluding parts of the lecture. Now this is the first image. Now please pay attention to every feature. Imagine that you're actually seeing a patient over here. So obviously the picture is very clear, so there's unlikely to be any media opacity, there's no vitreous inflammation. So look at the optic nerve here, look at the blood vessels, look at the fovea, and look at the distribution of the lesions. Is it largely in the posterior retina, is it in the mid retina, or in the peripheral retina? So when you're talking about looking at morphological characteristics as residents during your learning phase, this is very important to understand that morphology means distribution, morphology means color, the shape, the size, the margins, what's happening to the surface of the lesion, what is happening to the surrounding around that particular lesion. Okay, I hope you marked yes or no to this. The second image is this. Again, you're seeing a lot of lesions over here. Please write yes or no to whether this is a white dot syndrome. The third image is this. Again, you're seeing number of white spots, white, not white exactly, yellowish spots that are there. Fourth image. Again, pay attention to the distribution of the lesions. This is possibly the only lesion where you're seeing them white. Yeah, there are tiny lesions over here in this particular image. I don't know if it's very clear on your screens, but these are small images over here. One of the white dot does appear like that, but please. Okay, again you're seeing a lot of one central scar like this. Yeah, now after these test images, we'll come to the main topic now. What are the objectives of my lecture? First is to define. There's no clear-cut definition of white dot syndrome. So I've tried to define it in my own way. And then I'll give you a list of these entities. There are more than a dozen. I've listed only a dozen over here. What is common between all of these entities? And like I said, the clinical diagnosis is essentially based on morphological features. So you should have that descriptive ability. Now, retinal evaluation has no auscultation, no percussion, no palpation. So the entire diagnosis is based on your skills at inspecting a particular lesion. Use your visual cues very good to make a diagnosis. I mean, you should not jump to OCT, or let's say we'll do an angiography or an ICG. First is to describe the lesion clinically. That's the skill that all of us have to first inculcate, then is to be able to recognize. Now, many of them have a very good outcome, so those cases you should not load them with steroids. So it's important to recognize the vision threatening ones and the non-vision threatening ones. Even the non-vision threatening ones do develop vision threatening complications, so you should be able to identify those complications. Now, I've shown you some of these images, and I'll tell you why they were not white dot syndromes. They're mimics of white dot syndrome, and some of them have very sinister kind of pathologies associated. So as young residents, it's also important that we are always emphasizing, like you have descriptive statistics, there's something called analytical statistics. As residents at RP Center, I'd appreciate all of you thinking analytically also. Don't just be happy that, okay, this is the diagnosis, this is how a clinical picture appears. The important thing to ask is, why is this happening? Because more and more, we're going more and more cellular, we're going more and more molecular. So it's important for you. Now, these are all things that I've tried to put on in my own way, because like I said, I was trying to understand this topic. It came as a surprise to me. So I'll tell you what I feel is one of the events that's occurring in some of these diseases. Now, this is how I would like to define white dot syndrome. It's a group of rare posterior uveitis. Now, when I say posterior uveitis, there's one entity which is not purely a posterior uveitis. And I would appreciate any of my senior residents telling me, Unit 1 or Unit 2 senior residents, I don't know who are all attending the lecture, but if any of our senior residents there, one of these entities is not a purely posterior uveitis. Okay. Okay, I think I'll tell you. One of the rare entities is the multifocal choroiditis with panuveitis. It goes with the term panuveitis, but it is a part of the white dot syndrome. And I call this a triple I etiology, where we don't know, we're all presuming it's immune mediated. Immune deposits cause inflammation and some degree of ischemia. So the triple I etiology, immune, inflammatory, ischemic etiology, which affects predominantly the choriocapillaris, retinal pigment epithelium, and retinal photoreceptors. Now, some of these affect the retinal photoreceptors predominantly, some of these affect the retinal pigment epithelium predominantly, while others affect the choriocapillaris predominantly. But since the three are together, invariably there is some involvement of all three layers. So then you get these morphological lesions. We'll come to that subsequently. Now, there's a list of syndromes that are there, and amusingly, all of them have some kind of an abbreviation to it. And so, as first and second semesters, and maybe the third semesters also, it may seem intimidating. You don't have to really kind of mug it up. But by and by, I think you'll get to know what these kind of abbreviations mean. It will be used possibly by one of your senior residents during your ward rounds. I'll cover each of these. I'll show you some clinical pictures of each of these subsequently. Now, what do they share in common? Although it's called white dot syndrome, none of them are actually white. Okay. Now, you must understand, why do lesions have a particular color? Some of them we say are white, some of them are cream colored, some of them are grayish in color, some of them are reddish in color, some of them are blackish in color. So it all depends on the light tissue interaction. Like we say, the laser tissue interaction defines the kind of lesion that you get on using the laser. There's a similar kind of a light tissue interaction that is occurring, and almost always there are three things that happen. One is how much of light is transmitted, how much of light is absorbed, and how much of light is reflected. So that's what actually defines the color of your lesions. So when more amount of light is reflected back, there are lesions that appear white, and obviously it means that the lesions are more superficial, and the typical white lesion may be your soft exudates. But as the lesions get deeper and deeper, there is less and less light that gets reflected back, so the lesions appear yellowish and maybe orangish. When the RP loses its ability to absorb more light, it may appear orangish. So that's what actually defines. And sometimes you have melanin that comes in, and there's complete absorption, so those lesions appear black or dark in color. So none of these white dot syndromes are actually well understood. And none of them are syndromic. Now, when I say syndromic, when you say Marfan's syndrome, it means there is a constellation of signs and symptoms which are involving multiple regions of the body. Okay, here you have a constellation of symptoms and signs, but the important thing to understand is many of these are common to all these entities that I described, and these entities may move from one to another. It's a continuum of some of these have a continuum. If you follow up these cases over years, you will see that they may shift from one form to another form of a white dot syndrome. So technically, you should call all of these as inflammatory chorioretinopathies and not white dot syndromes. Now, if you go back and read up on white dot syndrome, you will see that under every particular entity, you will see the same thing written, that it is very rare, it is very rare, it is very rare. It occurs in young, middle-aged, healthy people. Only two entities, maybe there's a distribution that the men and women get affected equally, but otherwise predominantly the female gender is affected more often. Now, when you say this, you should again ask yourself, why is it that women are affected more often? And one thing that could be playing a role over here is, as youngsters, again, you must understand there are some estrogen receptors in the retina, in the choroid, and it's possible that there's some hormonal interactions that are occurring, and that may be one of the reasons that you're seeing a predominant gender predilection over here. It's been described after flu shots, other forms of vaccination, like I said, hormonal interactions, and then trauma, post-trauma, and in hypotension. Almost all of them present you with scotoma, some degree of photopsia, and blurring. Okay, predominantly if it is scotoma, they are central and paracentral scotomas. Blurring obviously means the damage is much more. Scotoma means that the damage is much more subtle. Now, why photopsias occur is not very clear, but many of them can present with photopsia. Many of these conditions resolve spontaneously, and so it's important not to mistake them for choroiditis and treat them with a lot of steroids. So important reason I summarized this slide was I'm not going to be saying the same thing, that it is rare and it occurs more in less in men or something like that. I'm not going to be repeating these things. I'm just going to emphasize on the morphological qualities of these entities and just trying to see if you can take back some descriptive ability following these slides. And the teaching slides are actually the ones that I've taken from the net. I'm not usually very fond of taking images from the net, but this is an online class and not an in-house classroom presentation. So I've taken these images freely from the net. And this is one such image where you're seeing that this is the left eye. So the media is relatively clear. The photograph is pretty good, so the medium should be clear. Look at the disc margins. Okay, the margins are not clear. There's some blurring of margins. Now there are multiple kind of yellowish lesions over here, and if you look at the margins of these lesions, they're not well defined. Obviously they're not discrete. They're all confluent lesions, and along the supratemporal arcade you're seeing that the confluence is pretty significant over here. The macular area is also looking possibly elevated. Now this is a picture that is very typical of APMPP, or acute posterior multifocal placoid pigment epitheliopathy. It's so self-explanatory, this particular term APMPP. So it's an acute presentation. The patient comes to you with blurring of vision, and it's usually bilateral. Okay, so one eye may follow the other within a matter of days or weeks, but it's a bilateral pathology. But it also resolves. It appears very aggressive. It appears very kind of dangerous looking, and you may be wanting to start them on steroids, but hold on over here. See them often. Call them a week later, call them 10 days later. So that window period that you have at observation saves you from starting these patients on steroids. So you follow them up and you see that the lesions start resolving. Now, how do you recognize that the lesions are resolving? Without getting into, like I said, fundus autofluorescence or your OCT, one has to again see the morphology of these lesions. Now here, if you see that the margins are not well defined at all, that means that these lesions are a little deeper. The other thing, when the margins are not very clear, means that the surrounding tissue is edematous. So once there is resolution, you see that the margins start becoming better defined, and better defined, and the kind of swelling, you look at this particular area, or if you look over here, there is some kind of elevation that you can see, so that starts taking a more flatter appearance. So when you see that, you can be very sure that this is not a multifocal choroiditis that needs treatment, and it's APMPP. Now, there are few indications when you have to treat this condition, and one is the presence of a visual acuity that is less than 6 by 12 or 6 by 18, and if you see some serious detachment, that's the time when some of these patients will need steroids, but not a protracted course of steroids. You can taper rapidly because this condition does not recur. Okay, and if it's unilateral involvement, you could also do with a periocular steroid injection, but no intravitreal injection in these cases. Okay, what happens when you heal? Okay, this is how it appears now. This is a picture bilateral. It appears also like serpiginous choroidopathy, and this has always been an issue for me, that serpiginous versus resolved APMPP or APMPP, they seem like two ends of a spectrum to me. The serpiginous form, where your immunity is very good, and the APMPP, where your immunity is very good and you're not developing damaging cellular side effects, while in serpiginous your immunity is not very good and you're going on to develop very damaging side effects. Okay, but this is a patient with APMPP. Serpiginous choroidopathy, you will not see a symmetry like this. This is more or less, I won't say 100% symmetry, but the lesions are more or less identical in both eyes. This kind of a pattern is not seen. And again, in AMPP, one important feature, you may have healing lesions and active lesions. You must remember that these kind of patients, they develop after a prodrome. So once the lesions start appearing, you may see few active lesions and at the same time few resolving lesions, but they completely resolve by 4 to 8 weeks. These are just to emphasize, although you can make a clinical diagnosis, this is considered characteristic of APMPP. You do a fluorescein angiography, you're seeing the laminar flow over here, so this is obviously an early phase of the angiogram, and what you're seeing over here is a lot of hypo areas deeper than the retinal vessels, because you're very clearly seeing the retinal vessels over here. So it could be inner retina, or it could be in the choroid. Obviously, we know that APMPP is predominantly choriocapillary and RP affliction. Now, some of them consider this to be ischemia, which I'm not very convinced, because even significant tissue edema will show up as hypofluorescence, and this possibly is because of tissue swelling more than ischemia. And during the later phases, you will see that these lesions start staining over here. Okay, so this particular early hypo, late hypo is considered very characteristic of APMPP. Another patient, this was one of the earliest patients that was described in literature. So you're seeing this, grotesque looking lesion over here. You feel that, okay, it's going to cause a lot of damage, and fluorescein angiography in this case is showing up a degree of pooling of the dye. So sometimes it can appear so sinister, the lesion, but even in these cases, this patient would have needed some degree of short course of steroids, but visual recovery is pretty good. Most of them recover at least 6-12 vision. Now, in serpiginous choroidopathy, macular serpiginous macular GHPC can also appear like this, but for some strange reason, you're not going to see pooling of dye over there. You're going to see localized edema around those active edges, but you're not going to see pooling of dye. It causes healing at one area, only the margins remain active. So pooling of dye goes against the diagnosis of a serpiginous choroidopathy. Now, OCT, I'm not going to go too much into OCT, because almost like I said, the 4 layers of your ELM, the myoid zone, the ellipsoid zone, as well as the RP and maybe the choriocapillaries, most of the pathology is localized to that area. I think Dr. Rohan has some collection and some kind of data on this. So, maybe he'll tell us something at the end of the class if he's there. Or you could meet him to discuss OCT features of these conditions. Okay, so here you're seeing some disruption over here of those layers that I was mentioning. So these are considered characteristic, but again, these appear in almost several of these white dot syndromes. This is another very again rare entity. You're seeing just a focal lesion. Now another important thing to understand is some of these white dot syndromes are localized around the region of the fovea and no more. Some of them are confined to the posterior retina, some of them to the posterior retina and to the mid retina, while others are confined, they go as far as the far retina. And the other important thing you have to see is, was the appearance first in the far retina or was the appearance first in the posterior retina? Again, when you look at the distribution of lesions, was the distribution predominantly, even if it goes right up to the aura or to the far periphery of the retina, it's important to ask yourself, is the lesions predominantly posterior or peripheral? That also aids your diagnosis. Now, this is a patient, again, they present to you with poor vision and central scotoma. You're seeing some disruption, an orangish kind of coloration to the fovea. Fluorescein angiography, very minimal kind of hyperfluorescence. So this is acute macular neuroretinopathy, and again very spontaneously resolving, but it may take much longer. Like APMPP, I said, takes maybe 4 to 8 weeks to resolve. This is sometimes said to take as long as 9 years to resolve, with some residual field effect that may still persist. Cause is not known and you do not have any treatment. This is one condition. Maybe I've missed diagnosing this condition because the findings are so subtle. So this is something called AZUR, acute zonal occult outer retinopathy, where the patient again presents to you with scotoma, significant vision loss, but the fundus may appear very normal, like in this particular patient, or you may notice some pigmentary changes. This is an infrared image that you're seeing over here. The retro image that you're seeing over here. So it's showing some subtle pigmentary change along this area. And on fluorescein angiography, you're seeing maybe some degree of window defect over here because the late phase angiogram, all the blood vessels are filled up. So over a period of time, this particular disease is known to develop significant pigmentary changes with vascular attenuation, and on autofluorescence you're going to see these kind of islands of tissue loss over here. Very rarely it's said that these patients can have something like your rejection line when you do a penetrating keratoplasty and you have a rejection line. There's something called a Jampol's line. This was first described by the Jampol's line or the AZUR line. So you're seeing this in this particular photograph over here, and also one of these active. This is unlike a GHPC edge. GHPC edges are much thicker, much wider. So this is a very fine line that you're seeing, and this again resolves spontaneously. This is a post of this patient, and you're seeing disappearance of that active line. So again, after healing, what happens in these cases? Like I said, I may be missing some of these situations where I have seen patients with this kind of focal pigmentary changes, always wondered why they were there. But it's said that AZUR patients over a period of time can develop these kind of RP, localized RP kind of changes that you're seeing over here. This is essentially intraretinal migration of pigment that you're seeing in this situation. Now this is another peculiar entity. So if you notice in this particular image, you're seeing some kind of reddish dots which almost look like hemorrhages over here. And if you look at this image, again an autofluorescence image over here, you're seeing these petaloid kind of lesions. This is an acute macular neuropathy. The first thing I said was, acute pigment epitheliitis. Let me just go back here, correct myself. Yeah, this was acute pigment epitheliitis, okay, also called Krill's disease. Now this is this is acute macular neuroretinopathy. These kind of petaloid lesions are considered very typical again over here. So you're seeing disruption of these layers. This also resolves spontaneously, but there could be some residual scotoma. So acute pigment epitheliitis, acute macular neuroretinopathy, they affect only the foveal area, and obviously it means that the cones are affected over here and there's no rod involvement. A very characteristic lesion over here. You're seeing these extensive lesions. Initially they could start off with some focal kind of localized lesions like you see over here. They look like the birdshot pellets, so it's called the birdshot choroidopathy. It occurs in a little older individuals by age, and then it progresses relentlessly and causes extensive pigmentary changes, as you're seeing in this particular patient. The autofluorescence images are very typical. Some patients may have perivascular leakage like over here, and cystoid macular edema is said to occur in a large majority of these cases. However, choroidal neovascularization is very rare. Now, this is the most common condition in the body that has a very strong association. Almost 90% of these patients are said to be associated with the HLA A29. Okay, but we have seen cases like this, but somehow HLA A29 has been negative in a few of them we could not get. Surprisingly, there are a lot of cases of birdshot choroidopathy reported from Pakistan. I don't know why we are not seeing so many of these cases just across the border. With the next entity, some of them include this as white dot syndrome, because in the active phase you're seeing these cluster of, again, yellowish lesions. You could mistake this for an acute pigment APMPP lesion. And if you don't, and like I said, APMPP generally is bilateral, but this kind of a cluster sometimes happens in patients who have a subretinal worm, ankylostoma. You have a small subretinal worm that is migrating. Okay, this is a subretinal worm that's migrating in the migrating in the subretinal space, so it leaves these tracks over here. So if you miss it's very difficult to find that particular subretinal worm because it's motile and very small. If you find it, you're supposed to be lasering those worms immediately. One urgent indication for laser is the presence of something called DUSN, or a diffuse unilateral subacute neuroretinopathy. If you don't find the worm and you're unable to treat the condition, it invariably goes into a situation like this where there is significant sclerosis or narrowing of the vessels, and obviously there's loss of retinal function. Yeah, I think in our setup, this is what we see most often, the multifocal choroidopathy and panuveitis. So these lesions can appear in the posterior retina, mid retina, or in the far retina, but usually they start in the posterior retina. They respond initially to steroids, but you see the moment you reduce the dose of steroids, new lesions keep coming up, and they involve and damage a lot of the retina over here. Some of these active lesions may have fluid collection. So multifocal choroidopathy with panuveitis may be one condition where you would treat, because I think this is one of the most aggressive of all the white dot syndromes, and I would not hesitate to treat these patients with steroids. It remains stable for some time. I'll show you some of one of my patients where she went on to progress and she's blind now. Okay, in the heal stage of multifocal MCP, you're seeing these kind of lesions. This is in the heal phase. There's a lot of pigmentation that sets in. Some of them develop these annular kind of a sclerosed ring over here. This is considered very typical of an MCP when you see this kind of an annular ring around the disc. Some of them have significant subretinal fibrosis. So I was saying uveitis with subretinal fibrosis is a separate form of white dot syndrome, but patients may initially present to you as multifocal choroidopathy with panuveitis, and if you see them in the late stages, you may make a diagnosis instead of uveitis with subretinal fibrosis. This entity is called multiple evanescent white dot syndrome. So it affects predominantly the posterior retina. This is a white field showing that there is not a white field, the montage that you're seeing over here with some lesions in the mid retina. Peripheral retina is rarely involved in this condition. In this, unlike in APMPP, you're seeing even in the early stages, the lesions are hyper, both early hyper, late hyper. So early hyper, late hyper usually indicates that there is no significant edema of these lesions, and there's very minimal disruption of the blood retinal barrier. Okay. So why is it called evanescent? This is again an online picture where you're seeing within a matter of few days, this is how it's appearing, and within a matter of few days the lesions have completely disappeared. Okay, so they're very transient, and that's why it's called evanescent. This kind of a granular appearance of the macula is considered very characteristic of patients with mutes. And when you see this granular appearance of the macula, always look for some few white spots that are there. These evanescent dots may not be so numerous. Sometimes they're very few. I thought I'll make this more interactive, but I don't know who are all present. Somehow I'm not able to see who are all present, so it's difficult. So I'll just carry on. Okay, this is a condition called punctate inner choroidopathy. And in the active stage, you're seeing these discrete lesions predominantly again affecting the posterior retina. And then later on, you will see that there is a degree of scarring. These kind of patients, almost 50% of them are said to develop choroidal neovascularization. So patients with punctate inner choroidopathy who present to you with vision loss, you must distinguish them from an active lesion like this and from a choroidal neovascular membrane, because these membranes also need anti-VEGF treatment, but they don't need recurrent injections like in diabetes or in ARMD. So distinguishing patients from an active nodule like this from CNV is very important. This condition also peculiarly affects women who have high myopia. Okay, it's more common in women with high myopia. Another series of images of patients with punctate inner choroidopathy. You're seeing the fundus photograph over here, and then you're seeing the early fluorescein angiogram, the late fluorescein, the early ICG of either eye, and this is the autofluorescence image over here, disruption on OCT. So this kind of multimodal imaging has become the norm, but it's actually not very necessary. If you see this kind of a clinical picture, you can stop any further workup unless you're suspecting a choroidal neovascular membrane. Now, a GHPC or serpiginous choroidopathy. Now, serpiginous choroidopathy can be peripapillary form, and it is called the geographic helicoid peripapillary choroidopathy, or it can be the macular form like you're seeing in this situation or in this situation, where the optic nerve area is pretty clear, but the lesion is largely in the macular area. Now, this is one condition that is extremely serious because it completely wipes out the retinal pigment epithelium, and almost 1/3 of patients are resistant to steroid. 1/3 of patients need very high dose steroids and immunosuppression to keep the condition quiescent, and only 1/3 of them may show some degree of remission with a short 1 or 2 relapses. Otherwise, it is relentlessly progressive, and many of these patients land up with low vision or blindness. So in this situation, you're seeing that there's an early lesion like this, and you can follow up these patients, and during follow-up, if you notice that the lesion is enlarging, only at that point in time you can initiate treatment and get the lesion under check. So it is important, like I said, to have that window period of observation, because you don't have to subject all these patients to the side effects of corticosteroids. These patients, obviously, now the fovea is threatened over here. You'll need to give them high dose steroids. This is one patient where this patient will probably have maybe 618, 636 vision. The foveal center is already involved, but fortunately the lesion has become quiet over here. In this particular situation, you have to ask yourself, should you be treating this patient, because the macula is entirely destroyed and it never recovers. However, this patient has active edges. So in this situation, you would treat this patient mainly to save the central field and not the central vision. And if it is unilateral, you could treat these patients maybe with an intravitreal steroid injection or a periocular steroid, and again not give these patients very high dose steroids for a very long time. So again, this is what happens. Like I said, they're relentlessly progressive. So over the years, it just progresses, and you're virtually seeing the sclera over here. So In contrast to serpiginous choroidopathy, this is said to be uh, relentless, persistent choroidopathy, where the lesions appear not in the posterior retina but they appear more in the periphery, and they may or may not progress to the center. Now, these lesions, you don't really have to treat them aggressively, but again, observe and see how they're progressing, and if the macula is threatened, only then you could treat these lesions. I was talking about uveitis with subretinal fibrosis. So this is the end stage of some of these, where there is an inordinately more amount of fibrosis than and scarring than what you normally see. So this, when you see patients with MCP at this stage, you would always make a diagnosis that multifocal choroidopathy panuveitis with subretinal fibrosis. Okay, very rarely we see this kind of a situation called POHS, or presumed ocular histoplasmosis syndrome. So these are called histospots, and very rarely this kind of I've never seen this kind of, we've seen patients with pseudo POHS, but this kind of a streak is I've never seen. This is called a histostreak. This is a multifocal Whittley-form lesion. Again, some of them consider this to be a form of white dot syndrome. So one of our own patients, there's another entity called acute blind spot enlargement syndrome. You can have subtle pigmentary changes, so you can never explain the scotoma or the visual symptoms of these patients. So it's the old Goldman perimetry charting, where there's a relative scotoma of the optic nerve. But these patients, again, even if you treat them, they're not going to respond, and the scotoma stays on for a long time. I've already mentioned when you have to treat these patients. One is when you have a serous macular detachment, when you have these kind of choroidal neovascular membranes. With OCTA, you don't need to do a fluorescein in these cases. Then when you have active lesions that are threatening the optic nerve or threatening the macula, and when you have cystoid changes in the retina. And this particular change is very peculiar to only birdshot choroidopathy. Okay, now we'll go back to the lesion that I showed you. Yeah, would anybody be able to, Abhijit, you're here. This I think you'll be able to diagnose. What is this? You've seen these cases, I think. I thought this would be... anyone in the audience? I really thought it'll be more interactive. This is a one-sided kind of a presentation. They do. Let me just see. Let me just see. Okay. Yeah, anyone in the audience? I can't make out who's there, who's not there. Yeah, okay. Navasi sends. Okay, Pruchner's retinopathy. Okay, bilateral. Sometimes they have a fracture, they have fat embolism, or some kind of a major surgery or trauma. Okay. Yeah, Navasi, now that I know you're there, what is this?
These are list of
Hmm?
This is list of articles.
आप ही बोल दो randomly हमारी resident. Okay, Ritvik will call out the names. Okay. Ritvik, randomly you choose.
Dr. Toshit is
Toshit. Toshit is asked almost every class. Toshit. I can't hear.
Ritvik's residents are answering the chat section. You can read that also.
I can't. How do I get the chat section here on the screen? प्रफुल्ल बोल सकते ना माइक्रोफोन ऑन करके.
But then this will get minimized.
Yes, sir, they can see, but there will be a lot of noise disturbance if they switch on their mic.
Oh, अच्छा, okay. So let me see chat box कहाँ पे?
Chat box.
Okay, Ritvik is just helping me with the chat box. Which are the new ones?
And the PIC histoplasmosis.
Navasi, you have not answered this. Navasis, I'm waiting for your chat. No, the SRs are there. Unit 1 SRs, anyone from Unit 1? Okay, these are tubercles. Okay, these are tubercles in a patient with, I mean, many times miliary tuberculosis or disseminated tuberculosis. So this is how tubercles appear. Okay, so this is not a white dot syndrome, and obviously, if you miss this and write it down as PIC, you'll be harming your patient. Okay. Yeah, Navasis again first. Unit 1, any of our SRs are there? Just anyone, Unit Sanket, any of our other SRs are there?
Written SRs, you can switch on your video. At least sir can see your face. So any written SR present here, please switch on your video.
Okay, Navashis, only you're here, I think, today. I really was hoping to make it more interactive, but Navashis, they reflect here.
Yeah, she has.
Navasis, okay, this is not for Navasis alone. Okay, this is essentially a patient with malignant hypertension. Okay, you've all heard of acute Elschnig spots. So all of these spots, they are pure white. They're all in the periphery. So you may consider this, and like when I say malignant hypertension, so you also have to take the bilaterality into consideration. The arterioles, maybe this patient is already getting treated. So you do see some narrowing of the vessels. But this is acute Elschnig spots in a patient with malignant hypertension. So again, if you diagnose this as white dot syndrome, so you can see what's happening and what harm you'll be causing your patients. Okay. Yeah, Vatsala, what is this? Aishwarya, you here? Aishwarya. Yeah, good.
Sir,
Wonderful.
lymphoma.
Pardon?
Sir, lymphoma presenting.
No, Aishwarya correctly said these are cottonwool spots. Okay, these are microinfarcts of the nerve fiber layer. So if it's bilateral, again like this peripapillary soft exudates, you will think of grade 3 hypertensive retinopathy is one consideration. But if you look at the blood vessels over here, the AV ratio is pretty normal. Okay, so this is actually one of our patients who had HIV microangiopathy. Okay, diagnosed patient with HIV. So you don't see HIV microangiopathy very frequently in our situation, or I have not seen so many, but this was one of our patients. Okay, these are microinfarcts in a patient with HIV microangiopathy. Sindhuja, that's good. You've got the diagnosis correctly. It's very good. Yeah, now this is the subtle lesions over here. Okay, these were cryptococcal again in a patient with HIV. Now, if you see mudes, when I said white dots, you may see that these things are like mute, small dotted lesions, but this was cryptococcal again in a patient with probably very bad HIV admitted in the ward. Okay, what about this, Aishwarya? Ritvik, आप भी बताओ. You also see this lesion and let me know. Bishti. Yield CNVM, okay. Etiology. CNVM is pardon? Post AMD.
It's also dragged a bit post BRB.
Okay, anyone from the thing, chat or something? I don't know. It's a little difficult taking a class like this actually. Okay, see, right at the beginning of the presentation of the class, I said, please pay attention to every single thing. Okay, first thing I said, look at the media. The media is absolutely clear. Then I said, look at the optic nerve head. Now look at the optic nerve head in this particular patient. Okay, the optic nerve head looks pretty normal. But the moment you shift a little bit over here, what are these? Okay, these are angioid streaks. Okay, a patient with, and I mean, he had pseudoxanthoma elasticum. So look at these over here. Okay, these are typical angioid streaks over here. Many of these patients develop a bad kind of a scar like this. So whenever you see what Abhijit was saying, a CNV in a young patient, please look for these angioid streaks. Some of them have other systemic manifestations also, which you need to get a workup done for. So you should never miss patients with these angioid streaks. Okay, now this patient mimics which form of white dot syndrome? Okay, uveitis with subretinal fibrosis. Like I said, those patients can also present to you with a scar like this. Okay. Yeah, now looking at the cellular level, like I said, probably is my last slide, I guess. Yeah, okay. Looking at the cellular level, what we're saying that the choriocapillaris is involved, there's ischemia in the choriocapillaris, but you should ask yourself that choriochoroid and the choriocapillaris is one of the most highly vascularized tissues in the body. Can it actually become ischemic? Okay, so it's unlikely that there is ischemia, but the pattern that we see in patients with APM, PPE in the initial stage and later on when they become confluent probably has something to do with the lobular arrangement. We know that these choriochoroidal vasculature, they have a lobular arrangement, so it probably has something to do with one lobule that gets affected, inflamed, and then that is what is showing up, and it's less likely to be because of ischemia, because there is free anastomosis because I mean between the vasculature. It's not like end arteriole like you see in the retina. So ischemia is highly unlikely, and I'm not convinced when people say that ICG is showing up ischemia. Now, situations like serpiginous choroidopathy, it's predominantly the pigment epithelial layer that is affected, and here you must understand that the pigment epithelium cannot regenerate, and every pigment epithelium actually supports hundreds of photoreceptors. So even a single RP that gets damaged affects the functioning of the photoreceptors, and here there is a very close cell to cell contact, and so any infection or any kind of an inflammation that immune mediated inflammation which affects one pigment epithelial cell can spread to the adjacent cell, and that possibly explains the way that you see a GHPC that is progressing. An RP that is entirely damaged, it's no longer able to survive, shows atrophy, but the adjacent cells are infected, and so you're seeing that active edge over there, and that is possibly the reason that you see patients with serpiginous choroidopathy. Now, conditions like acute pigment epithelitis or patients with acute macular neuroretinopathy, like I said, they predominantly affect the fovea, and fovea means the fovea means the cones, okay? So there are no rods over there. So what's peculiar? Again, we see that when, like I said, these are transient kind of conditions, but again, the photoreceptors cannot regenerate, okay? Once a photoreceptor dies, you cannot replace those photoreceptors. So what exactly is happening over here? Which part of the photoreceptor is actually able to regenerate? Okay, we all know that you have an inner segment and an outer segment, and you have these rod membranes and the cone membranes. So these cone membranes and the rod membranes are continuously getting removed, and they're continuously getting replaced. Okay, it's possible that patients with acute macular neuroretinopathy or acute pigment epithelitis, although it's called pigment epithelitis, possibly have an involvement of these membranes, cone membranes, and so once the insult is gone, the membranes that are regenerated are healthy, and so you don't see any abnormality again on OCT. Okay. And now coming back to the white spot syndrome virus, there is something called a white spot syndrome virus. Like I said, even on using an academic search engine, I got this particular reference, and then when I looked it up, it actually affects shrimps. Okay, and it is nothing to do with the human white dot syndrome. It's supposed to be a very contagious and deadly disease, and I just put it up as an interesting, what should I say? Okay. Yeah, now I'll show you some of our own patients. What's the time? Okay. Yeah, these are some of our own patients. Okay, this patient is a DUSN patient, possibly the second or third patient that we had seen. This patient was diagnosed as cystic circus from Muzaffarpur, and he was referred to our center. And obviously, we all probably missed it. I had not seen this patient. I was walking out of the clinic, and the patient came behind me, and he showed me the pictures. This thing had been taken at Muzaffarpur. Okay, I've just made a small listing of the copy that he had, printout that he had. Okay, it had been taken at Muzaffarpur, and unfortunately, none of our residents who were there had made any effort to see the thing. Patient would have offered it to them, but in that rush of our clinics, nobody had made an effort. I was in the corridor, and when he showed me this, immediately, obviously, you know what you're dealing with. By the time he came to us, we could not see this worm any longer. And so the moment you see this worm, you need to laser the worm. Okay, and these are the tracks. When he came to us, these are the tracks that were there, and ERG changes and all were obviously there because it was quite some time. Another patient, okay, this kind of wreath kind of hyperfluorescence is very typically seen in patients with Nawasish. Okay, this is again you're seeing these white dots. Aishwarya, what is this? Okay, white dots and some macular granularity. So the diagnosis would be
Mutes.
mutes. Okay, yeah, this is mutes, and this is one of our own patients. So this kind of a hyperfluorescence is considered very characteristic. You don't see it often, but I was fortunate to have this. The young girl who I was saying is blind now. Okay, so this is how she presented when she was just 16 years old. There was some disc edema like this. She was being managed outside in another private setup in Delhi. She came over here. We also couldn't really understand. A lot of imaging was done because initial presentation was of disc edema. There was some kind of an inflammation of the pineal gland, very non-specific. We didn't know what. But then slowly, she started showing up these nummular lesions and this annular ring, very typical of multifocal choroiditis with panuveitis. She has severe scarring now, vision of 3/16 one eye and with difficulty 6/36 in the other eye. Nevertheless, she runs an NGO. I mean, I'm just telling you that some of these patients are, they are so good. She runs an NGO on her own now. Okay. So you also see that there is peripheral subretinal fibrosis. So there's an overlap. Initially, we didn't know what was happening. Maybe you could think of Azure over here because there's just disc involvement. Then it becomes like an MCP. And later on, there is a degree of subretinal fibrosis also. Okay, there's a continuum that you're seeing in this patient. Okay, Abhijit, what is this? इसमें multifocal नहीं, multifocal is not there, no? Aishwarya? If you're seeing one large patch, confluent patch, okay, so multifocal would be many. Here you're seeing one cluster here, maybe one over here and one over here. Okay, this is a typical GHPC. Okay, it's knocked off both the peripapillary area and the macula, but there are also some heel lesions over here and a small lesion over here. Okay, GHPC is probably the most common entity, or serpiginous choroidopathy is the most common entity that we see. Okay, this is multifocal. Okay, but again, if you see the lesions, those lesions I was talking about in birdshot choroidopathy, okay, many of them, they don't stain even on fluorescein angiography. Okay, so there is a macular edema over here. There is, and BRC is known to have vitreous involvement. Okay, the vitreous can be hazy, so we're not able to capture very good image over here. But on fluorescein, you're seeing macular edema, you're seeing this multifocal lesion. So this is a patient with birdshot choroidopathy. What about this patient? Abhijit. I have only Aishwarya, Ritvik and Abhijit to interact with. Okay, see these small lesions that are there, okay, predominantly involving the posterior retina. There are also some lesions in the periphery, but the predominant involvement is the posterior retina. And if you look at the choriocapillaris are very easily seen, a kind of tigroid fundus. So most likely this patient also has myopia. So obviously this is punctate in a choroidopathy. Okay. So this, what is the most striking picture in this? The subretinal fibrosis. So the initial event may have been something, but the current diagnosis would be uveitis with subretinal fibrosis. Okay. So actually, initially I thought I'll have a very small talk on white dot syndrome and speak more on masquerade syndrome, because that had more importance. But somehow by and by I kept enlarging the lecture, so I don't know how important or useful this would be to all of you. Okay, this is again another patient. What is this? Which phase of the angiogram, Abhijit? Yeah, okay, this is a very late phase of the fluorescein angiogram. So what are you seeing in this?
There is somewhat blocked fluorescence.
Yeah, okay, so there are some multifocal lesions over here. First is this, okay? So this appears more or less normal, then you're seeing these multifocal lesions which are hyperfluorescent, and then you're seeing there is a vascular occlusion over here, there is remodeling, some looping over here, there is breaking of the column, blood column, and obviously some leakage around that, and blocked fluorescence because of retinal hemorrhages that are there. Okay, so this was a patient of APMPP with vascular occlusion. Now APMPP is one condition where you can have involvement of the cerebral vessels also. So if they complain of meningeal symptoms, headache, so one should also get a neurology review done. So they may consider doing a MRI or a CSF analysis. So this is the only condition where you can have something that can cause significant harm to the patient. Okay. Yeah. So any questions on the chat box? Navasish, any questions? Yeah, Abhijit.
That one picture which shows which had tubercles, could it be how to differentiate from POH?
Yeah, let's go back to that. Now this one, no? Yeah, see POHS, like I said, there is some peripapillary involvement over here. Okay, it looks like there is some peripapillary involvement. But at the same time, no, you will see that POHS has much fewer lesions in the, and the most important thing is to go to the background of the patient. You never make a diagnosis. Okay, you need a small case history also. So if this patient did not have a history of tuberculosis, had presented like this, so maybe you would think of PIC more than POHS. I would think of PIC or something like that. Okay, so POHS typically will have some healed lesions that are there, and they also tend to develop choroidal neovascular membrane. POHS also is known to develop peripapillary choroidal neovascular membrane. Okay, and usually tubercles are also bilateral. And yeah, and the POHS scars are very pigmented, and tubercular, even if this resolves, they don't cause tubercles after they resolve also, they don't leave back pigmentation. They're more hypopigmented. The main thing is they're deeper. One is they're deeper, and possibly because the insult is not so severe, except in cases like I said, multifocal choroiditis with panuveitis, or in patients with birdshot choroidopathy. So probably the insult is more protracted and possibly more severe also. Okay, and many of them are either very focal, like you have mutes, you had acute macular neuroretinopathy, or they are spontaneously resolving. The insult is very transient, so maybe that is the reason. Okay, the only takeaway here is that identify the condition. First is to get the history. There's a systemic background, so then obviously none of the white dot syndromes have a systemic association, so you should rule out that thing of making a diagnosis of white dot syndrome if the patient has a systemic history. And if it is a white dot syndrome, avoid using a lot of steroids. Okay. Praful. ठीक आप बोल दो और ये skip कर दो, skip. Done?
Yes.
Thanks Aishwarya, thank you Abhijit. At least it makes it feel like a classroom, at least because of you both over here. It's very difficult presenting, no, not used to this. और इसको इसको डिलीट कर देते हैं वैसे ना.
Thank you.